Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello and welcome back. This is Adam Rosen, and you're listening to the Total Knee Tips and Pearls podcast. So we're going to continue on in these next few weeks with Season 4, and more classifications are coming your way. Coming up tomorrow is the Gruen classification, so be sure to listen into that. But I want to actually soapbox today and do a little freestyle, little separate bonus episode just to talk to you about something, get something off my chest, and tell you actually where I think we're going to be in the future. This is something that's really dear to my heart, something I've spent a lot of time thinking about, and something that I've tried to get out there and reach out to people, but I found the industry, I'm not sure, is farsighted enough to see the influence of this in the future. And I've actually reached out and tried to contact people at DeepMind and, with Watson, IBM, I thought would be a potential option, but, I'm not sure venture capitalists and these big AI companies see a huge financial benefit for this. But what I'm trying to focus on, and actually, I've been trying to create an algorithm. So I want to throw this out there and see maybe someone else has been thinking about this too, or along these lines, or maybe is interested, or maybe has a contact. And, we'll say, hey, you should talk to so-and-so and they could go down this path. But it comes down to total knees. I've looked at all the total knees that I've done since 2006 in practice. I think I did my first total knee as an assistant as part of the operation around probably 1996. And I've seen a lot and I've thought about it a lot and I'm really fascinated by it. But like all of you, the question that we're all trying to answer is, why are 20% of patients dissatisfied? 15 to 20%. And, depending on how much data you collect from your own patients, you may have a very specific number on those that are extremely satisfied or neutral. But we really need to know why those people are dissatisfied, because the problem is we keep getting thrown answers from industry. And we get navigation, and we get patient-specific blocks, and we get now robotics, and all of that stuff is being thrown at us. And at the end of the day, it's an answer, but it doesn't answer the question as to what is the question. Like, the question is, why do 20% of people feel that the knee is not what they wanted it to be? Why are they dissatisfied? That's the question. Is it the implant? People always ask, is there a best implant? Is it the cuts? Is it the alignment? Is it the soft tissue balancing? Is it something else that we haven't even thought of yet? But why do some of these people not like their total knee? And, for most of us, if you've done training and fellowship and you've done lots of these and you've read and you've practiced them, and you're going to put a good knee in, whether or not you're using manual instruments, intramedullary, extramedullary, navigation, robotics, what have you. And we've seen the studies, that have shown that, with navigation and robotics, you have better, mechanical alignment, more accurate cuts, and less deviation, less standard deviation, and less deviation. But there's been studies that have shown that that hasn't led to any improvements in outcomes. And some studies have shown that it's actually led to higher revision rates. So, you can always find a study that says why it's better, why it's worse, why it's neutral. But again, it is the garbage in, garbage out. Whether or not you're using navigation or whether or not you're using robotics, you're plotting points and you're picking these arbitrary things to make the x-ray look good and to restore your alignment. And then you expect your patient to do well. And once you do enough of these knees and you see enough of these patients in the office, what you start to realize is every so often you see an x-ray that looks perfect. I mean, you throw it up at the academy on the board, you throw it up at AUKUS in a lecture because it's perfect. But the patient is unhappy. They don't like their knee. It doesn't feel right. It hurts. It's painful. And then you get these other knees where you left it in a little bit of varus or a little bit of valgus, and you're like, what did I do? And then you walk into the patient's, doc, this is great. 1 month, 100%, full recovery, no pain. And the question is, why? So that's what we have to figure out. So this is my idea. This is my philosophy. This is my thinking, is that we're going into a generation where technology is everywhere. Honestly, in orthopedics, technology is actually pretty slow to the game. I mean, you look at most other things, we have tech everywhere, and it's been really slow to come into the operating room, but it's there. I'm just not sure that it's going to decrease the number of dissatisfied patients. So I've had the experience lately. I've actually had the experience to test and trial 2 augmented realities. And that's not exactly where I think we're heading, but I think it's really, really cool. I actually got to play with one, which is CT based, and it was really cool. I don't think I've put a pedicle screw in probably 20 years, but I was able, through the sawbones to actually put a pedicle screw in, looking at this augmented reality, and puncturing it through the skin. Basically, it was like playing a video game with my Oculus Quest, but, with the sawbones. It's really cool. A lot of applications there. And, additional augmented reality, basically nav in a headset, cool stuff. But I think the idea of wearables, is one way of where we're going to head. But this is my thinking, though, is that it is augmented reality, but with artificial intelligence. And that's why I've been trying to find people that are interested in this, or find people that have contacts that are interested in the idea of artificial intelligence and deep thinking, because I've started to create this thought process of this algorithm of all of these different factors that would be factors in the preoperative setting, the radiographic setting, the operative setting, the postoperative setting. And there's a lot of data points. I don't know which ones are important. And what we would have to then do is collect all of those data points and follow all of those patients, and then see who does well and who doesn't do well. And what you really need to do is pick 20 or 50 really good surgeons. Okay, well, how do you do that? I mean, you could use name recognition. You could use institutions. You could query their patient-reported outcomes and see who has the best patient-reported outcomes. Let's pick those, and then take these docs, capture all of these data points, follow all of these patients, and then see who does well and who doesn't do well, and plug all of this into this machine, and let the artificial intelligence speak for itself and figure out which points are important and which points are not important. And when patients do well, and the implant is here, or this is the implant, or the balancing is here, or the alignment is here, and this is what it was like pre-op, and this is what it's like post-op, then we start to know where we're headed. Because what if we could figure out if somebody is in varus or if somebody is in valgus? Maybe we don't want neutral alignment, and it's the idea of gentleman's varus. You've heard people talk about this, the varus knee, maybe leaving a little bit of varus. Okay, well, how do you do that accurately? The valgus knee, maybe you leave in valgus. Some of these joint lines, the varus of the proximal tibia is off a little bit, the distal femoral angles, pretty much within the ballpark. But what about the ones that are really off? These proximal tibias that are really in varus, or these distal femurs that are really in valgus. Should we treat those patients kinematically? And patients that are more in that bell-shaped curve of, more of the normal, quote, end quote, knee, maybe you can treat them mechanically. Who do we leave in 1 degree of varus, 1 degree of valgus? Who do we rotate in 1 degree of internal rotation, external rotation? When do we anterior? So you can do all this stuff in the computer, but nobody knows which patients you're supposed to put where. So what I envision is that you have the wearable and you're looking at the knee, and you can see exactly within a 0.5 millimeter or a 0.5 degree where your tibia cut is, where your slope is, where your resection level is, where your femoral distal resection is, where your femoral rotation is, where your femoral anterior posterior positioning is, and having all that data. And then real time, also having a separate screen, which is basically like a chess engine. So if anybody's ever played chess, there are these great chess engines. And what they've done is they've assimilated every move from every game basically since the beginning of time. And it's figured out what the results are from every single move that you play against whatever opponent you're playing. And it can already tell you 20, 30 moves down the road what the outcome is going to be. You have a 90% chance of winning. Or it will say, yes, this is the best move. This is an alternative move. So imagine you're a community guy, and imagine you're doing total knees. And imagine you have this wearable, and it can tell you very accurately what the degrees and millimeters of your cuts are. And you set it up for, 0 degree cut to the axis of the tibia with a 2 millimeter medial resection of this varus knee. But based on the captured data on the patient, it's going to tell you that you know what? We've looked at 20 high volume surgeons and we've looked at the outcomes of their knees. And it's going to say, actually, the best option is you should take 2.5 millimeter resection at 1 degree of varus. And the outcome of your knee will be better. And the same thing for a valgus knee. And maybe it's going to tell you when you should cut a knee kinematically and when you should cut it mechanically. And when it's going to tell you to change, this or that to affect the balancing in the soft tissues, because we all know that, some patients are loose and love their knee. And the next patient's a little loose and they hate the knee because it feels unstable. You make some person tight as a drum, is usually the young male, short and stocky. They love tight knee. Take an 85-year-old lady who's, lax everywhere. You tighten up her knee and it's painful. It's sore. You're tenting her collateral ligaments and pulling them tight. So we don't always know, who do you leave loose? Who do you leave tight? We know about the joint line and where we're supposed to put it, but it's easy when something looks weird, right? Someone elevates the joint line and somebody, cuts the tibia and a little bit of varus and somebody oversizes the femoral component and the patient's in pain. And we all want to say, oh, I know why. It's because the x-ray looks weird. Or, you have anterior knee pain because they didn't resurface the patella. So you just bought a second operation. And guess what? The cartilage on the patella wasn't the source of the pain. You replaced the patella cartilage with plastic and they still hurt. So the idea of capturing all this data would then allow you to have this real-time heads-up display of telling you basically from 20 or 50, fellowship-trained specialists in knee replacements that we believe the best potential possibility is to do this, not that. So those are my thoughts. I'd be kind of curious to see in 10 years or 15 years if we're there. I think it's going to be at least a few years just from getting a program like this going to even capture the data and let the machine do the learning. But it's an interesting thought. It really kind of begs that question again, that when we talk about 20% of patients with what we would consider as surgeons successful total knee replacements, why are those people unhappy? We have to really step back and ask, why are they unhappy? Not because we haven't hit these parameters of the mechanical alignment and our accuracy of our cuts on the tibia and the femur, because if that was the case, navigation and robotics would have solved it and we would now have 100% of patients that are happy and satisfied. But we're still not there. So I really think this is that interesting little step of, do these abnormal shaped knees, are we supposed to cut them and correct them and do things to the soft tissue to make them straight in our mind? Or should we do things based on a patient's individual personality of their knee? I always talk about that, not the personality of the fracture, but the personality of the knee. What is their posterior condylar offset? What is their slope? What is the distal femoral angle? What is the mechanical axis and alignments of their joint and the tibia and the femur and the anatomic axis? And, how do we try to recreate what the patient had before they developed an arthritic knee to best balance the tissues and make the knee kinematically aligned and functioning? So at the end of the day, the patient's happy. So I don't know. That's a whole lot of thoughts. It's a whole lot of information, but guess what? It's my podcast, so I get to do what I want. And until next time, stay safe, keep listening, share the information. I got a whole bunch of really cool classifications coming up. A couple other little things too that I want to throw your way because I'm not sure that people have heard about all of them. And then I'm really excited to let you know that we are going to have some really cool interviews coming up. I finally got all the rest of my information or all my equipment and an extra mic. And I've got some people that have already agreed to sit down with me, and we're going to have some really, really cool lecture or interviews coming up with some really, really interesting people in the world of orthopedics and joint replacement. So I get to pick their brain and you get to listen to all of their answers. So until next time, I'm Adam Rosen. Thanks. You've been listening to the Total Knee Tips and Pearls podcast. My 2 cents on where we're going with augmented reality and essentially not a chess engine, but a total knee engine in your face telling you what would be the best possible outcome for a particular cut, position, angle, depth, resection when you do a total knee. And hopefully we can take that 20% dissatisfied rate down to 5%. I'd be happy with that. Take care. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review it helps other people like you find the show. Until next time, stay safe.